So we're going to go down and do this in a one at a time here. So I'm going to do this first one. This first one, look at the size of this guy's abstract. I mean, can you think of it's huge. But what's the title say? CPR compression strategy 30 to 2 is difficult to adhere to, but has better survival than continuous CPR when you're trying to do it correctly. And I think that this is important because when you look at the things that matter in CPR, it's not drugs anymore. There's nothing in the drug box. The drug box is now empty. There's nothing in there. We don't need the calcium bicarb, the epi, all that stuff that we used to give and teach the paramedics they ought to be using, and all the issues about how they work and all that. It was all wrong. So we basically wasted a lot of time. We waste a lot of time too. But so what matters is now electricity and the quality of the CPR. So they basically are comparing continuous CPR, where you sneak the breaths in, which you would intuit would be the best way to go, because pumping is more important than breathing. But they basically said if you do it well, the 30 to 2 ratio is the way to go. Any thoughts about that? What is the paramedics doing now? Monday through Friday they do one, and then the other week they do the other one, or how does this work? You know what they're doing?
I think we need to be really careful about having these like dictums that thou shalt do 30 to 2, thou shalt not do 24 to 2, and 36 to 2 is way too much. You know, like it has to be a bridge to somewhere, and yes, high quality, like do it well and high quality CPR, but I don't want to browbeat people that they're doing it wrong. Just do high quality CPR, push on the pump, and if they have a shockable rhythm, they're more likely to survive, and if they don't have a shockable rhythm, it's dismal. It has to be a bridge to somewhere. That, putting on these, and to support that statement, they have these mechanical devices, right, that do it just perfectly, the perfect depth, the perfect rhythm. They've even got music playing in the background that's the right music from ABBA about staying alive. And they've shown mechanical CPR is not superior to CPR. And so that informs my position that, if they've got a shockable rhythm, great. Super. And if they don't, it doesn't mean you give up and you're not a nihilist, but I don't want to overemphasize that, 30 to 2, not 32 to 2.
You sound like Jerry Hoffman. You sound exactly like, where's Jerry's friend? This is exactly what he would say.
Yeah, but what's even worse is he doesn't know that it was the Bee Gees that did Staying Alive and not ABBA. So that's
See, I'm all about the 80s, not the 70s.
He's a Canadian, Yeah. What can you expect here? And the Canadians certainly don't want to.
Those mechanical ones you can set to just be continuous or set it to do 30 to 2. And that doesn't matter. If you set the mechanical one up, that's fine. The problem is a lot of it's done just by people. And forget about counting the numbers. The 60-year-old or the 60-pound tech who's doing it 1 minute, and then the next time you've got Gonzo, the orderly, doing it the next time. There's too much variability there. I'm not sure how they were able to rationalize that here.
We have a question.
Yes. Well, they have a sore chest.
Yeah, they definitely,
That's right.
A lot of them, like we saw in the papers, end up doing okay after they stay in the hospital for a while and whatnot. But certainly, I put them at risk factors. We had one of our attendings, you probably remember him well, who coded on shift and got immediate CPR, high quality, all that, and we were visiting him every day in the ICU, and he would alternate every day by just saying how grateful he is, and also yelling at us for doing too high quality of CPR because his ribs are killing him the whole time. But yeah, I mean, it is. I think for some people it becomes clinically significant, and for others it's not without harm. CPR and
generally a good idea to rest on shift. Well, not on a single covered place.
Now, first of all, it's not a good idea because now somebody has to cover you.
That's right. The schedule. All right, let's move on. It basically, in the title, says the answer. If you try to do it well, your 30-to-2 ratio, which is people have been talked about in the past, maybe a little bit better. Maybe if it's 31 and 31 and a half, but
It's almost like Monty Python. Thou shalt count to 3. Thou shalt not count to 4. When throwing the holy hand grenade. But yeah.
But
Those
basically,
no Monty Python fans out there.
it's quality. The quality that will matter.
But it was a secondary analysis. I mean, the
Oh,
evidence
here
is
you go.
so weak. I mean, it's a secondary analysis.
Doesn't CPR matter?
CPR matters.
But if this gets
I just
in your-
don't know what the rate matters, though. That's what I don't know.
But I think what you don't want is for this to be in your head, like, oh shoot, I should be doing
Yeah.
exactly 32, or like instead of doing the high quality CPR that I'm used to, just do the high quality CPR.
Yes.
And yeah, it's funny, we do the ACLS training with the residents at the beginning of every internship orientation, and we teach them the 30-2, and we do the whole ACLS course, and a year or two later, they come back and they teach the ACLS course, and they always come back and they're like, man, the only time I've ever done 30-2 was when I taught this course, and I've never actually done that again. But I wouldn't let that.
But you wouldn't want them to go home one night after a shift and go, geez, I wasn't going fast enough, and that's why they died. Right. Or I was pushing too fast,
probably-
and that's why they
that
died.
was probably the
because
reason.
we are wired that way. And so I want to de-emphasize that so they don't go home and blame themselves about it. I mean, you're a residency director. Come on, ease up, right?
You got wellness.
Okay, wellness.
All right.
All right, so number 2, this is me. This is the effect of vasopressin and methylprednisolone versus placebo on ROSC in hospital cardiac arrest, so INCAs. And there's been some previous literature. It was from a Greek trial that was done a number of years ago, I don't know, like 5-6 years ago, that suggested that adding vasopressin and methylprednisolone for an in-hospital cardiac arrest could improve outcomes. And so this was a large randomized control trial done in Denmark, so done in a different setting. 500 plus individuals were randomized after they got their first round of epi, either to getting vasopressin and methylprednisolone, or placebo plus the standard care that was going on, or the placebo and the standard care that was going on. And their primary outcome was ROSC. And of course, that's easier to find, right? And we see that in the out-of-hospital cardiac arrest trials where ROSC, did you get ROSC? But people don't really care whether you get ROSC, at least the patients I've talked to don't care if they get ROSC or, survival to hospital admission, survival to hospital discharge. What they care about is survival with good neurologic function. But their primary outcome was ROSC. And so they found that they got more ROSC with this. But when they looked at their secondary outcomes, 30 days, there was no difference with regards to survival, and there was no statistical difference with regards to favorable neurologic outcome. And so the author's conclusions were, if you have patients with an in-hospital cardiac arrest, you can increase the likelihood that they'll get ROSC. However, we're not sure if this will give them a long-term benefit for survival.
Yeah, this isn't the first time that they've studied more squeeze during cardiac arrest. There were the older studies where they looked at like high dose epinephrine. If we just put more squeeze on the vessels, like could that increase, improve outcomes and whatnot? And it didn't. I mean, you can shock any heart back to life if you give it enough squeeze. And
it's amazing, what you remember. And I remember the high dose epi stuff coming out during the TV show ER, and they got to give her high dose epi, and it was one of the residents, and that. It just imprinted on me, that terrible episode. But yeah, it never made sense to me that, causing all this vasoconstriction everywhere to every other organ to increase a blood pressure or get an electrical signal was going to be good outcome for people. So anybody doing VSE, vasopressin, steroids, and epinephrine for their arrests?
Nobody's going to admit to it now, for crying out loud.
Really? Okay, yeah. No, okay, good.
All right.
What's that, sorry? Norepi?
Yeah.
Does that make a difference?
It doesn't seem any of this makes a difference.
Yep.
It's just,
Yeah.
it's
Yeah,
just.
but
makes
remember,
us feel
this
better.
is in-hospital cardiac arrest too, right? So it's different than out-of-hospital cardiac arrest, which is more dismal, right? And it's adults, so it's more cardiac and shockable as opposed to kids, which is respiratory in general.
All right, number 3, in keeping with the theme of what doesn't work, effective intravenous or intraosseous calcium, they couldn't have just said effective calcium, versus saline or on return of spontaneous circulation. Bottom line is it didn't work. In fact, they stopped the trial early because it was killing people. 19% in the calcium group had sustained return of spontaneous circulation compared to 27%. And then, as Ken noted, favorable neurologic outcome, which is what's important. They did it at 30 days. It was in 7 people in the calcium group and 15 in the saline group. So you can retire your calcium chloride.
So you guys mentioned earlier that I have this podcast, and I have 80s theme music for the introduction to each podcast, and I covered this, and it's called the Coca Trial. Which song do you think I used there, Al?
I have no idea,
Oh,
but
you
it
do.
goes through
You do.
your mind.
It was. No, it was
there you go. Ramon's got it.
No, it was at the Coca for Ocas. Anyways, I don't. Who sings that one? Coca. Coca
That's,
Cabana.
Barry
Barry Manilow.
Manilow.
Barry Manilow. Yeah.
Rick, you really couldn't find another person?
No, we were desperate.
Stuck with him.
Yeah.
All right, we're up next. Abstract number 4, a methodological appraisal of the heart score and its variants. This was published by Green and Schweiger. This is actually a paper revisiting the validity and the utility of the heart score. This is actually this paper makes me sad. Because you know, how many of you have been using the heart score these last few years and documenting it in your charts and feeling pretty good about discharging people with the heart score? So this paper is basically poking all kinds of holes in the heart score. And Schweiger, he works out of UCLA, really smart guy. He published a paper years before, I think 2014, about the methodological standards for clinical decision rules and going through a systematic checklist to ensure that the clinical decision rule tool are being adequately derived and validated and then applied to clinical practice. And I know Ken is a huge fan of these checklists. If you listen to the SGEM, I'm going to shamelessly plug the SGEM. It is a very good podcast.
It's free.
It is free. And if anybody's interested in kind of getting a little deep divey into like the methods as you're reading through these papers and curious about what confidence intervals and all these different things mean, on MRAP too, they have these, what is it? Talk a Little Nerdy. They're super, super great. Anyway, but this methodological appraisal of the heart score systematically goes through all the steps and checklists. And basically, here are just a variety of reasons that Schweiger feels the heart score should not be universally applied. One, it ignores some of the risk factors, such as sex, and it doesn't go into as fine a detail into some of the historical factors. You know, part of the heart score is the subjectivity of, do we think it's a high risk or a low risk, no risk history, but it doesn't objectively define exactly what those features are. The heart pathway does a little bit more, but he questions whether it's better than Gestalt. There's poor inter-rater reliability. When he reanalyzed some of the data in the meta-analyses, he found that the pooled sensitivities are lower than what was initially found. So I'm very curious to hear what Ken has to say about the heart score and how much he utilizes it. But first, I'd like to hear from Al.
No, just I never bought into it for 2 reasons. One is, every time they compared it to clinical Gestalt, they found clinical Gestalt did the same or better, because the first thing in the heart score is, do you think they're having an MI, or do you think they have a cardiac problem? So that's an issue. The other thing, as much as I hate to admit this, Ken taught me this, and I don't quite understand it, so he's going to have to explain it again. You can't apply risk factors to an individual patient. So the patient in front of you who smokes, is hypertensive, and has a family history, it has the same, at that point in time, risk of an MI as the person in the next bed who's never smoked, doesn't have hypertension, and is a world-class athlete. And Ken keeps explaining it to me, and you're going to have to do it again, why it doesn't work for one person. Risk scores only work for a population.
Well, you said it there. It's a population. It doesn't. We treat an N of 1, right? We care about the patient in front of us. We don't treat a certain percentage of a population that has an increased risk factor. So it's about probabilities. And I think you said a great thing about, clinical gestalt. How do we derive clinical decision instruments? You take a whole bunch of information and you run it through this meat grinder and you find which item is most closely associated with the outcome of interest. So basically you're crowdsourcing this room of clinical experience and says what works best. And at the end of the day, you find these 3, 4, 5 items from what you guys have generated that says works the best. And then you apply that and you find out, hey, it's pretty close to what you guys do. Well, you're basically giving clinical experience to people who don't have clinical experience. And so I use these clinical decision instruments to teach, to bring people up to speed. But you wanted to know my comments on this? So, yeah, don't call it a rule. You're tempting me to break the rule if you call it a rule. But this was a residence research project. And so I think she gets a great shout out. Barb Baracus, I think that's how you pronounce it. Bacchus? Yeah, in the Netherlands. Great big shout out to her. This was a resident project. All right, but it follows the same arc that we often see, and that arc is, wow, isn't this cool? We should apply it. The numbers look great. It's 100% sensitive. It works all the time. And then as time goes on, hey, it doesn't work that well. Hey, there's a whole bunch of problems with this. Hey, why did we adopt this in the first place? This is crap. Right? And it follows that arc of, so I'm like Al, I wasn't too enthusiastic when it first came out because that's interesting. We'll have to see how it pans out over time, and I've never used the heart score.
Although, how many of you have it integrated into your EMR?
Of course you have to.
There you go. So they're trying to help you out and do you a favor by having you not having to remember any of that. And I think some people view it as, if I complete the heart score, it helps me from a medical legal point of view, and that's maybe why it's in there, to show that I did it, I did my best, and that heart score was part of the effort, and it's widely adopted. It's like TPA. It's widely adopted, but not necessarily pristine in terms of how it works.
I agree, and it's interesting because some of you may work at a shop like mine, where some of the dispo decisions that cardiology wants implemented are like, if the heart score is higher than a certain level, then we want them admitted for observation. If it's lower, then then you can decide whether or not you want to discharge them and that kind of thing. And I think that it's a tool, but it should never, as with all clinical decision instruments, overshadow your clinical judgment.
Oh boy.
We need a younger person to do this one. They talk about here the comparison of ST segment elevation myocardial infarctions versus NSTEMIs and occlusion MIs versus non-occlusion MI. How do you get a non-occlusion MI? How does that work? And these paradigms shifting, they point out that we used to do Q-wave MI, non-Q-wave MI. Then we did STEMI, NSTEMI, and they're saying, well, there's a lot of people who have NSTEMIs, and we don't think they're the bad ones, but actually when you look at the morbidity of NSTEMIs, they're probably worse than STEMIs. But they said, we found 30% of the NSTEMIs have occluded arteries that can be opened, and yet they're taking forever to be brought to the cath lab because it's viewed as, and STEMIs don't go to the cath lab right away. The STEMIs go to the cath lab right away. And this is an attempt to do better. But I must admit, the more I read about this, it's like, well, how do you diagnose one of these? It's not nearly as easy as what we did for STEMIs and NSTEMIs. And there's a physiologic approach to this, but it's like, I just struggled through this. I want to stick with the Q-wave and non-Q-wave MI, if that's okay. Does anybody know anything about this?
Well, I think this is like one of the, we were just talking about in the post-cardiac arrest where you have NSTEMIs, do they need to go to immediate cath? Can they go delayed? And earlier on, even in the not post-ROSC patients, there have been studies on can non-STEMIs wait to get their cath. And I think what is happening now is in the cardiology world, they're trying to identify that subset of patients of non-STEMIs that maybe should get earlier cath compared to a delayed cath. And using this occlusive model, but again, yes, this is very confusing of how you would.
Well, plus they talk about being much better in terms of the subtleties of the EKG and trying to tease out these people. much beyond, most of our capacity, to be probably honest.
Yeah, but you just increased the pool of NSTEMIs by about 1,000% with the high sensitivity troponins. I mean, the nursery is about the only place you can get a blood draw where you don't have a positive troponin. So I'm not sure what's going to happen then.
They're going to add it to the APGAR score. But one of the things is that I think that changing the nomenclature can be good if it makes you think about, just because they have an elevated troponin does not mean they have occlusive disease. And you need to think about other things like, oh, is this rate and demand related? Is this because, myocarditis, because they had a reaction with their COVID vaccine? I mean, or they have COVID, and, is it a non-inclusive STEMI, or will cleaning out the pipes help if there's no occlusion there? But you can have an elevated troponin. They're in renal failure. They've got other things going on that causes their troponin, especially these high sensitivity, low specificity troponins, to be high.
I'm sorry, I'm not able to help.
You can't help.
I can't help you on this. If you go to the internet and start printing stuff out trying to explain this to you, I think it's really obtuse, to tell you the truth. They're just trying to find that 25% of the NSTEMIs that really ought to go right away, and not. And this paper points out that those people who had NSTEMIs traditionally would wait days before their cath, and that prematurely cathing NSTEMIs for a lot of people would hurt them. So we're trying to.
All right. Look, somebody understands it. Right.
That's the NSTEMI population that you're talking about, that trying to identify, right? I don't know if there's any studies out there, but there are a lot of cardiologists that if you're still having pain,
Yes.
blah, 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 and there's no STEMI, we'll still pay for the
Persistent pain will get you a trip to the cath lab, for sure.
Yeah, that is one population that could potentially benefit, but I think we're still trying to find that, like who that population exactly is. Yeah, and this is a new sort of change in paradigm, mind shift that it's just good to know about this nomenclature, and this is a evolving sort of.
I thought I was going to be able to do more, but I kept on reading it. And how do you get a STEMI that's not occlusive, non-occlusive STEMI? How do you do that?
Somebody had a question over there.
Go ahead. Well, they have a definition, but the definition is based on a cardiac cath.
Yeah.
It's like it's a little
Circuitous.
How do you do that? They're talking about flow.
That addresses most of it. So the it's differentiated retrospectively, basically. And this isn't a nomenclature that we're using. We're talking to a colleague. This is more for research purposes than cardiology.
Well, according to a lot of these people, they say this is a new paradigm, time to embrace it. But if you don't know how to diagnose it, and there is this attempt to find these people, but don't overcast, because you hurt some.
Yeah, I think they're trying to.
I feel that this paper has defeated me.
I think they're trying to I don't think it's just for research purposes. I think it's trying to be more clear about what we're talking about, and if it's occlusive as a non-ST elevated MI, but if it's an occlusive event with an elevated troponin, that would be more likely to benefit from opening up the artery, as opposed to a non-inclusive elevated troponin cardiac event. And well, that's what they're trying to tease out with the nomenclature, because to consider other things that may have caused an elevation in your troponin. Right? Because there are, half a dozen to a dozen other things that can do that. But as soon as we see, the troponin's up, but we don't have a STEMI, troponin's up, go to the cath lab, right? As opposed to a reflex. You're trying to, okay, maybe we just take a step back and think about this, as opposed to having a monosynaptic reflex. Take them to the cath lab. I think that's what they're trying to caution, to find those patients.
There's about a 10-page thing that I printed out on the internet this morning that has all kinds of EKGs and Welland sign and all these other more subtle manifestations of coronary ischemia that you should pick up. it's really puts a lot more burden on you to become cognizant about other. It's more than just ST elevation.
Well, speaking of,
Save me.
occlusive disease, early CT coronary angiography in patients with suspected ACS. This was a randomized trial. For a while, we've been saying, listen, if it's obvious, it's an ST elevated, the person comes in, older, white, male, bald, clutching his chest with Levine sign, and the ECG and the troponin, do we need to do a CTA on that? No, right? And the opposite end of the spectrum is, let's say it's a young person, and young is always defined by how old you are at the time, but let's say they're in their 20s and all this kind of stuff, and you're like, yeah, this isn't it. They don't need a CTA. But what about that intermediate risk group? Can we actually tease that intermediate risk group, and is that where CTCA will help us? And that's what some of the advocates of this CTA program were suggesting. So this was a randomized trial design, 37 hospitals in the UK, looking at patients that they had to have raised level of troponins and an abnormal ECG. And the primary endpoint was all-cause death, so very patient-oriented and very objective. You're not mostly dead, right? You're either all dead or not dead. And then, and also included in that was certain types of myocardial infarctions. And this outcome was at 1 year. So they got close to 1,800 participants randomized into the trial, and they got the CTCA or just standardized care in the UK. And the primary endpoint occurred in about 6% of both groups. So they said, really, there wasn't an advantage to doing this, even in the intermediate group, with regards to their outcome. It did reduce the rates of invasive angiography in the UK and modestly increased the length of stay in the hospital when you did CTCAs. But there was no difference with patient-oriented outcome. There's some big centers, I think most of them, are they in New York, where they really push hard for these CTCAs?
It used to be University of Pennsylvania was really pushing hard for it.
Yeah, was it? Okay.
But then it kind of fell out of fashion. I had one done. But the only thing I can tell you is as soon as about 5 minutes after they push the dye.
You have that warm flush and have to pee?
Well, there's that, but everything else goes away, and your butt stays warm for about 20 minutes. So if you're looking to have a warm butt, this is the test to have done. Again, I said to the tech, I said, is this unusual? Is it just that my ass is so big? And she said, no, everybody has this problem. I said, okay.
That's all you need to know about CTCAs.
Yep, that's it. All right, but talking about CTCAs, look at number 7. This is and I don't want to pick on Dr. Maida, who did this study, who's a great researcher, but this is just a weird study. Major adverse cardiac events after emergency department evaluation of chest pain. What they did is they looked at all the articles that looked at should you get a CTA, should you go to cath, how should you do it, and here's their conclusion. Patients presenting with chest pain who have a coronary artery CTA showing less than 50% stenosis, a negative ECG stress test, echocardiography, or a stress myocardial perfusion scan in the past 12 months can be discharged without any further risk stratification if their EKG and troponin are reassuringly given low major adverse cardiac events. So basically it says if you get an EKG and it's negative and the troponins are negative, and you do any of these diagnostic studies, they can go home. Okay. That's it. It's like, I thought that was called an admission.
Was that?
Now, the one caveat to it is he or she said if you had it done in the last 12 months. And that was the kicker to it. And that's a bit of value to it. But I'm just thinking, isn't that what we do when we put somebody in the hospital?
Next up we have, so we're going to shift gears from, we need to get out of this coronary stuff. Abstract number 8.
I did that. I covered that in the syncope. We added it to the syncope one. Yeah.
Oh,
the only thing you have to do, though, and this is a great researcher because he does a ton of great research, is I want you to pronounce his name.
Oh, I know him.
He's Dr. T.
Yeah.
No, he's not called Dr. T. So he's from Ottawa. He's part of the Ottawa group with Ian Steele and the bunch. And he's called Team Venk because his first name is Venk.
Well, that's where his online calculator, if you want to look it
up,
is
Team
under
Venk.
teamvenk.
Yeah.
I
He
mean,
doesn't run his own site, though.
Yeah, he does a great.
He's a very good researcher and
yeah.
a great guy. Yep.
Okay. So if you want the online calculator, teamfenk.com, CSRS. Next.
Bear down.
Go ahead.
The reverse vagal maneuver. Do you guys know about the reverse? They think that this is pretty cool because you can teach patients to do it. People in third world countries can do it. You don't need a doctor to do it. And so it's a new tool for treating SVT. Supraventricular tachycardia. Vagal maneuvers are simple, but not as necessarily as effective as we might like them to be. The modified Valsalva maneuver is appears to be the most effective. I've got a picture of it here, right there. You can see this picture, I'm sure. Anyway, there's a young lady here. You blow out and hold your nose, pinch your nose tightly, and close your mouth.
And then that's when you pass out.
And then you try to inhale. Close your mouth, pinch your nose, and try to inhale.
The reverse.
It's a reverse, and it says it is more effective than the standard one, and so that you can have patients do this without any helpers.
This gentleman's trying it, but he's standing up. Please don't do that.
I'd like to have someone stand behind.
No passing out here.
This was a case series. Yeah, this is, you know.
It was small.
Like 11 patients, 10 of them like reverted with this reverse thing. It's interesting. I've never tried this. But
Well, I'm going to expand your world, you know.
Yeah. Have you tried it, Ken?
Yes.
This one? How's?
I've only tried it a couple of times and have not had success yet.
Obviously, it's an operator kind of
I got an N of 2.
effective.
But I have tried abstract number 10. I have tried the modification to the standard Valsalva maneuver where you put their legs over their head kind of thing. People have done that. You know, you get them to blow really hard into a 10 cc syringe and move that plunger, and they're sitting up at the time, and then you lay them down and put their feet up in the air. There was a trial done about 5 years ago that showed about a 40% success rate, and this does the same. It says about a 40% success rate. And, you know, reflecting back on my practice, it's somewhere between 1 in 3 and 1 in 4 that I find that it works. And I do this while they're setting up the other stuff. I say, hey, we'll give this a try, and I usually give it 2 shots. If it doesn't work, then we're moving on.
Well, what if I have this on an airplane? And can you help me out? And, you know,
Well, I think you have to climb then.
I
Get the legs up.
would try mine before I tried yours.
Yeah, but you'd have to be in first class, and they'd have to be in one of those pods where you put your feet up in the air and they bake warm cookies.
So yours is for mine is for in the coach people.
Yeah, that's coach. Developing nations.
We have a question.
I got my first successful one on film and I tweeted it, and it just shows it's where it's really fun.
Which one was it?
Revert.
Mine, not his.
The inhale one or
suck?
the revert?
The modified, put the legs over the head. Cool. So I had I use another technique from time to time because these people will come in and they've had repeat episodes and they're like, I don't want to be shocked, I don't want to be sedated, or I don't want to have that adenosine because it's a horrible feeling. And I had one of those patients a number of years ago. And so I called the kitchen for stat basin of ice, and we did the mammalian dive reflex because they were a younger individual, and by that I mean in their 20s. And I explained that we're just going to hold their hair back and put their face in a bucket of ice water. And we had the monitor on, and of course they were tacking along, beep, 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 and then we put them into the, hold their breath, put them in the ice water, boop, boop, boop. And so we trained her to do that at home, but with someone else supervising, so she didn't, drown.
Yeah.
But yeah, no, it worked really, really well. And when I was doing my master's in physiology, I used to teach the mammalian dive reflex lab and have everybody hooked up to monitors, and we take all these, second-year students and put their faces in a bucket of ice.
I bet that was a real popular class.
I got good.
Both of them.
Yeah.
All right, moving on here.
It's easy to do in Canada. It's just take a swim in this lake here, and then it's the same thing. Number 11. We can do this one very, very quickly. Basically what they did, and this is a nice study, they followed a bunch of people who came into the emergency department and had elevated blood pressures. And we've all seen like these people. And it's, just because you're nervous and you watch them for a while, but they still have elevated blood pressures even after they're not nervous anymore. And it said, and now we have to let them know about it and who they're going to follow up with. And there's lots of articles. Should you start them on something? Should you get lab tests on them to check their renal function and everything else? What they said when they looked at this is these people are at an increased risk of complications of hypertension. And they looked at the composite outcome of stroke, transient ischemic attacks, acute coronary syndromes, heart failure, those types of things, death. But it doesn't happen for an extended period of time. It's like we all know, high blood pressure is a disease, but it's not a disease that needs to be addressed immediately. It's a disease that needs to be addressed over the lifetime of the patient. So we don't have to get overly excited about these people who have high blood pressure. We just need to make sure we close the loop and that they have good follow-up and at long term. Because you know yourself, if you just take somebody and go, oh, so you have high blood pressure, we're going to start you on some lisinopril, I want you to follow up. They'll take the pills for a couple days and they didn't have any symptoms from their blood pressure, they're going to stop. So you really need that kind of coach, primary care provider who's going to keep them on that path of taking their blood pressure medicine. So their argument is that the isolated elevated blood pressures in the emergency department are not associated with increased morbidity for at least 2 years after discharge, is what their conclusion was.
And this could have been, I don't want to minimize the research, but the Journal of Duh, because, the Framingham data, that's based on 10 years, right? If you've got elevated pressure, was it 5 years? 25 years, right? So like how long do you feel responsible for that patient that came into your emergency department, whether it was hypertension or not? The call the next day, yeah, I feel pretty responsible. I sent them to my VSA clinic or vital signs absent clinic the next day. But do you feel responsible in a week, a month, 25 years? How many people in this room have unknown hypertension right now? This suffers from denominator neglect and base rate neglect. What's the base rate of people in the general population with hypertension that aren't being treated right now? So this should come as no surprise and reassure us that they can be seen by their primary care physician.
Well, this is one of the biggest favors you can do to somebody, because they come in with a sprained ankle or something like that, and they're getting a thermometer in their mouth or their head or some other orifice, and the vital signs taken, and the blood pressure, if it's outside the range of normal, and then you repeat it a little bit later in their stay or before they're going, kind of thing, is still outside the range of normal. You've done a heck of a lot more for them probably than taking care of the sprained ankle for which they came into the emergency department for. So,
and you look good. You can say, listen, we've taken care of your ankle, but I treat the whole person. And your blood pressure's up, and maybe it's up because you sprained your ankle. I don't know, but if that's up for a long time, that could be dangerous. And so I want you to go see your primary care physician and take
the only clinical study I ever did was at County when I was that was in 1975, which was before some of you were OVA even, and we did a study on people who had high blood pressure in the emergency department, and then we would have them come back a couple of days later, and they would have their blood pressure taken when it wasn't. They had a separate person to do it. They didn't have to wait. They're not stressed anymore. And a substantial portion still had high blood pressure. So it was kind of like, it wasn't to say, oh, well, you're probably upset about being here. You can't rely on that at all, because you're going to miss people who have persistently elevated blood pressure. And I think you've done them a big. The other thing about it is, you take a blood pressure and the number's abnormal, you are obligated to do something about abnormal numbers. You can put it down and you can say, well, I'm going to do it again, or I'm going to refer them. But you got to do something with an abnormal number.
We have a process in our place where we have an electronic form or a form, depending on the individuals who we're sending it to send it back to their primary care physician and say, could you please look into this? Their blood pressure was up today. When they came in, either for their blood pressure or not for their blood pressure, and we have that closed loop. So it'll be in the system, it'll be documented, and their primary care physician gets it. And I'm allowed to say that because I'm board certified in primary care and do primary care as well. And so I see these people and follow up.
I'll be perfectly honest with you. If I'm seeing somebody with a sprained ankle, I don't even see the vital signs. It's like, unless the nurse comes to tell me and says, hey, by the way, their pressure's 200 over something, I don't even see them.
But it's impressive. This is like in this study, 1 out of every 2 patients had elevated blood pressure, and 75% of those with like no prior diagnosis. This is it's impressive.
We did a study a long time ago, study like in here, and the higher the blood pressure was out of the normal range, the least likely it was to be observed and noted and referred to the patient.
Interesting.
And the least likely they were to have a headache, actually.
Just one other comment. I work at the VA now, and we get a lot of referrals from primary care, telephone triage.
Oh, yeah.
Yeah.
So the patient comes in 3 or 4 hours and gets better. So there's also the point, which I've been telling patients, is this is not going to hurt you now. And I wish we could educate primary care that way too. Like, no, 160 over 110, that's not an emergency.
Yeah.
Oh, I get the pharmacy. They stick their, they're waiting for their prescription to be filled for whatever they're on. It's not a hypertensive drug. And they go, oh, they got a blood pressure. Stick it in. 145, go to emerge.
All right. Abstract number 12. Administration of a beta-lactam prior to vancomycin as the first dose of antibiotic therapy improves survival in patients with bloodstream infections. All right. It's a mouthful. This is basically the background for this study is the authors were curious about whether or not giving a beta-lactam first, broader coverage, like a cephalosporin, penicillin, those kinds of things, or giving vancomycin first for bloodstream infections, would there be any changes in outcome if one was given before the other? Their hypothesis was that the beta-lactam would do better if given first. Why? Beta-lactams are broader coverage. Beta-lactams have faster infusion. You can get them in 15 to 30 minutes. Vanco takes an hour. And they
hand waving now?
What is it?
The hand waving?
Yeah.
Yeah, they're hand waving. They're like, all these, reasons why it would work.
Yeah, exactly. The introduction was all that hand waving. And then they did this retrospective observational study looking to see if this actually played out. And what they found was out of the 3,400 patients greater than 13 years old, 80% had gotten beta-lactams first, 20% had gotten Vanco first, and they looked at 7-day and 14-day mortalities. What they found was that the beta-lactam group had lower mortality. Okay, but there's a few issues with this. One, again, this is hypothesis generating. This isn't a definitive thing. They're demonstrating maybe a potential association. We have no idea whether the patients that were getting the beta-lactams in the first place were, maybe they were giving Vanco to the sicker ones. Who knows what the rationale was. But also, when they did the chart review, there's no mention of, and this is very common if you read up on chart review studies, where the person, the MD that was doing the chart review was not blinded to the outcomes. So there's always a potential for bias there. So there's some bias in this study. But it is an interesting question of whether or not something very simple, if you just gave the beta-lactam first, give the faster antibiotic first instead of prioritizing the Vanco because it's broader coverage, unless they have a known staph infection, makes logical sense to me.
I will tell you, our sepsis police beat us up about this, and justifiably so, because exactly what you said. It takes an hour to run the Vanco in. The cephalosporin can go in a lot quicker, but they were more interested. They could care less about the outcome. The criteria to get it in, within 3 hours, is what they were more concerned about.
But again, you pointed out, this was observational data. So it's hypothesis generating, and there could be unmeasured confounders responsible for the results that they saw. And so they were cautious in their conclusions, and they said may, right, which could be replaced with may not, reduce mortality. And the hand waving, we've been doing this for more than 200 years. There was a study on sepsis in 1809 looking at bloodletting. And up until that point, bloodletting was the standard of care. If you weren't bloodletting, what kind of doctor were you? Osler was bloodletting. You need to release the evil humor if they're septic. You need to take out volume because this is causing problems if you're septic. And if they didn't get better, you clearly didn't bleed them early enough. Or you didn't bleed them long enough. Oh, they're right-handed. You should have done the bloodletting from their right dominant antecubital fossa. All this hand-waving and rationalization. And so this Scottish medical student decided to do a randomized control trial on it, and he randomized people into bloodletting or not bloodletting if they arrived with camp fever. The number needed to harm, death, was 4. Like people were dying, 1 in 4, if you did bloodletting. But it was the standard of care. And so I'd be very cautious about, oh, well, it makes more sense or it does this. I mean, we are very smart individuals that can rationalize just about anything based on pathophysiology. And until you do the RCT.
Well, while we're waiting for the RCT, what would you do there?
I wouldn't act on this, no. Why?
But you do for the metric, like you said.
Yeah, and we don't have those metrics.
Or just,
Check
match
the box.
antibiotic to the thing you think the patient has.
Yeah, exactly. I mean, they even say more ill-appearing patients. And they did that propensity score matching, and that's like statistical jiu-jitsu to try to get closer to randomization. But it doesn't, right? And so, unless you're capturing every single thing about those patients, you can't control for that. So, yeah, no. Pardon me? Why what?
Why wouldn't you do it?
Because I assume no superiority to doing it. His
point is that there's no harm in doing it.
What do you mean there's no harm? Did he demonstrate no harm? Did he demonstrate no harm? How many times have we said that?
We're just beginning 4 days here.
Yeah, you're stuck with me. I mean, in science, we start with a null hypothesis, right, of no superiority, and the time to accept a claim is when you have sufficient evidence to accept a claim. And if we assume that there's benefit, right, that's intervention bias, right? And and we often underestimate or underreport or underpublish harm in trials. So I'm going to side with there was an umbrella review that was just published in Academic Emergency Medicine looking at a systematic review of like 400 different, things that we do in emergency medicine, and looked at, do we have high quality evidence to support that care? Anybody want to guess on the percentage? Anyone?
88?
8%? Too high.
No, 88.
8%? 88? No, too high. 3%. It was 2.8% of
what did they include in there?
High quality. They were. I'll send you the reference.
No. What were the procedures they included?
430 something different things, and there was only 2.8% that had high quality, unbiased evidence, i.e., level A evidence to back up what we're doing. And that's consistent with, you look at the American Heart Association recommendations, 8,000 recommendations. They did a study on that, and they found that 10% had level A evidence supporting it.
Oh, these weren't procedures.
Not procedures, treatments. Treatments, defined as medications, interventions. Yeah.
But to your point in your question about would you do this, I think as a matter of routine, I also wouldn't do this as a matter of routine.
Yeah, it doesn't mean you can't do it.
But it doesn't mean that you're not doing it. Yeah, if your clinical judgment tells you to give the beta-lactam, give the beta-lactam.
Absolutely.
Yeah.
Well, now you have a little bit more a piece of information added into your home computer there that says, I always knew that it should have been the way.
But I think this would bias.
At some point, hopefully there's an RCT and we get better info. Well, in this study, they actually more routinely gave beta-lactams first. 80% were getting beta-lactams first anyway. I don't think there's this problem all around the country where everybody's giving Vanco first. They're just pointing out that, hey, if you are going to give Vanco first, realize that there's some issues with it, that it takes a little bit longer, that in this study there was an association with, not as good of outcomes.
Yeah. That's fine. I just wouldn't say that it decreases. I wouldn't claim that it significantly decreases mortality. I don't have justification for that.
It just seems reasonable. It just seems reasonable.
Yeah, but they had a randomized control trial of giving 2 grams of ceftriaxone up front for suspected sepsis patients in the pre-hospital setting, and it was a randomized control trial. You either got, we think they have sepsis, and so obviously giving antibiotics earlier will make a difference, and they randomized them to 2 grams of ceftriaxone in the truck on the way to the hospital, or placebo for suspected sepsis patients. You go, even if there's, what's the potential harm? They're probably going to get antibiotics anyways, giving it earlier, and they found no benefit.
Well, abstract number 14 explains that.
Well, first we're going to do a nice, easy one.
What's that one?
Improving hospital mortality rates when you implement a sepsis team. So you have any person that comes in with a fever, you just push the button, the sepsis team comes down to evaluate the sore throat, whatever it is, kind of thing, and you're going to.
Rate was 91.
You're going to. Well, they had to have 2 SIRS criteria.
One of them.
If you had 2 of them, you were in, and the mortality rate went down substantially, and every other measure that they measured was improved. ED length of stay, hospital length of stay, time to lactic acid, time to antibiotics, all were significantly decreased when you had this sepsis team, which does make a lot of sense. And if everybody's so concerned about the clock running, this ER doc's taking care of all these other patients. He's going to drop everything and start the clock.
Well, this is like the extreme version of like a code sepsis or a code, like you have a whole team. Of course, if I had a whole team for just ankle dislocations, we'd have the best ankle dislocation outcomes in the ED, like in the world. And if you had a whole team dedicated, but we don't have like infinite resources in any ED that I've ever been to where I just have like the luxury of having a whole team for the cardiology cases and the sepsis cases and these cases. So of course, like you have a whole team of people that are dedicated to that one thing, it's going to be better.
But you made the point really well. Your specificity for the ankle dislocation is 100%. Your specificity for you're septic or not, and that's what Ken and Rick were making fun of, is the criteria for sepsis are just so broad. You're going to be pulling this team down for everybody. You're right. You'll do better for the every time you hit the sepsis patient correctly, but you're going to have so many other people who aren't going to meet the criteria, or are going to, I'm sorry, I said that wrong, are going to meet the criteria for sepsis and aren't going to have it.
I'm sorry, 2 SIRS and you're in.
And I'd love to see the longer term data after the implementation. This is a before and after study. And whenever you throw money at something and resources at something, it improves it. Right? And I mean, even a Hawthorne effect comes into effect here, where, we'll change the lighting. Right? And, that means we're being studied. We're going to do a study and look at, how effective this sepsis team is. So, of course, but I'd like to see the 5-year results.
I'd like to also see the results of all the people that weren't septic and how their mortality changed.
How their C. diff is going.
Yeah. Well, the people with CHF or a little tachycardia who got 30 cc's per kilogram of fluid, yeah.
A flood. All right, number 14, that's me.
I'm just trying to be helpful here.
I know.
You could take this abstract back to your hospital and say, let's
have a sepsis.
You got some really bad numbers.
But
you're looking really bad.
From a meta response, though, why don't we fix the problem and address the issues within the emergency department and the flow and the resources and stuff like that? Because didn't like
or do this.
Or do that? Because 1975, like when you were coming through, didn't we create this specialty that we would see everyone and we would take care of people and we would diagnose and treat and work up and all that stuff? And now you're going to have code sepsis, code stroke, code MI, code this, code that, and I'm going to be like, what am I doing here?
Yeah.
Like,
No,
what
it's
am I
even
doing?
worse.
Now you're going to have cardiology, infectious disease. You're going to have all these subspecialties, and I'm like,
We're going to be given ketamine.
okay,
How,
because that's why I like being an emergency physician. I like doing all that stuff.
but how many people here have had the misfortune of some new member of your department calling a code in your department and seeing the mayhem that happens when 10,000 people descend upon you? Or most of our cardiac arrests are pretty quiet. You're standing there, a nurse or so, to give a little bit of this, give a little of that shock. 4,000 people come in all shouting instructions at the same time. Yeah, I think it would be very disruptive to have a sepsis team show up in the emergency department.
I mean, to the author's credit, they're trying to fix a problem.
Yeah, no, and
Just trying to help out.
And
Okay, let's not be realistic here. Come on.
all right, so number 14 is mine, and this is most emergency department patients meeting sepsis criteria are not diagnosed with sepsis at discharge. And so it's a retrospective cohort study, so it's a low level of evidence looking at this. Used the 2016 sepsis 3 criteria and used discharge diagnosis using ICD-9. So there's a lot of fuzziness in there with regards to how accurate they're going to be. But over 8 years, they had more than 3,000 patients that met this sepsis criteria, and only 25% of them met explicit criteria and half met implicit criteria at discharge. So that means 3/4 of them didn't explicitly at discharge qualify for this diagnosis of, didn't have a diagnosis of sepsis, and it was 50-50 if you were using implicit. So, and then they did some mathematical hypothesis, sort of hypothetical stuff about, what's the harm, and you pointed that out already. And I'm not the person that pulls the trigger on 30 cc's per kilogram, even on the patient that I'm like, yeah, they've got sepsis. I like to, what do you guys call it down here? Targeted therapy, or I provide individual patient care. It's not, oh, you qualify, the alarm goes off, you're getting 30 cc's per kilogram, and I walk to the next room. I'm looking at the patient, I'm trying to gather all the information about them, and use like if they have 2 myocytes holding hands, shaking hands, and a big baggy heart from congestive heart failure, and maybe they're, I'm not just giving, there's potential harm is what I'm saying. So be careful. Be careful out there.
One of our docs had an interesting observation, and I don't know if anybody else has seen this, and I certainly have once he pointed it out, that people come in, they have like this kind of borderline systolic pressure of like 90, so you give them this big fluid bolus of normal saline, and the next thing you know, their pressure bottoms out. And he's convinced it has to do with the chloride and everything else, and I think he may be right that, giving a big bolus of a hypertonic solution may have some adverse effects that we're not really paying attention to. Because then the next thing you know, you're putting a central line in them, and they're getting the norepi, and
the lungs down, and
yeah,
it's just.
All right, number 15. Number 15 is a little bit of a disturbing article. They looked at this pediatric health information system for kids with Nursemaid's elbows, radial head subluxation. And they looked at 45 pediatric EDs, and that may be the problem that they're looking at pediatric EDs and not general EDs. And what they found was radiographs were performed at 28% of the visits, and it ranged from 19% to 41%. Almost half the kids got an X-ray of a nursemaid's elbow. And then some other findings. They found an upper extremity fracture in like 0.3%. And if the kid was over 6, you were more likely to have a fracture than a radial head subluxation. I don't know, but isn't this a clinical diagnosis? And even if you don't have the history of the elbow being pulled, the kid comes in, they're holding their hand they're holding their wrist like this. You run your thumb over the radial head and you can feel it's out. And it's like, here, Mom, hold Twinkie's arm here, and you go like that, and you feel a click, and the kid goes, eats a popsicle, and then home they go. I don't know. I'm just amazed at the X-ray rate of these people.
Don't you get a post-reduction as well?
I only X-ray these people when there's a clinical, and even then, when I send them over, they come back after the X-ray tech has reduced the elbow for me. So, it doesn't happen that often.
I mean, obviously, you've made 3 attempts and you can't get it back. You get the X-ray, but it just seemed awful high.
Yeah, I agree.
But the history's key too, yeah. Like if they had the trauma and all that stuff.
You mean the funkle, the fun uncle doing the helicopter thing, yeah.
Oh yeah, like that. All right. Where are we at? Abstract number 16. Do non-steroidal anti-inflammatory or COX-2 inhibitor drugs increase the non-union or delayed union rates after fracture surgery? A propensity score match study. All right. So if you've come to these courses enough, I think we review one of these like every year about whether NSAIDs either delay healing or increase rates of non-union. And we've reviewed papers that show some association. We've reviewed papers that show no association. Here's one more study to cloud that even further. It was a retrospective study of upper and lower extremity fractures and any kind of surgical intervention. And then out of 8,700 patients, about 200 of them either had non-union or delayed union. And they looked at those subgroups and they found that the patients that had gotten NSAIDs for less than 3 weeks were fine. And the ones that had NSAIDs for greater than, or COX-2 inhibitors for greater than 3 weeks had higher rates of non-union. I'll be honest with you, I have no idea what to do with this NSAID stuff because when I just reviewed another Cochrane paper on this. It seemed the literature is all over the map. It's unclear whether this actually delays non-union. Do we deprive patients of these medications in fear that it's going to cause non-union? It's unclear. I think that one of the main takeaways is if you can get away with Tylenol, some people will do just Tylenol. But I still routinely prescribe NSAIDs, and I just give them for a shorter duration until they can get to the orthopedic, who can then decide what kind of therapeutic regimen they want to put them on.
Can yell at you for
berate me for the non-union.
what the heck is he doing?
What do you guys? I'm curious. What do you guys prescribe NSAIDs for your fractures?
Yes.
NSAIDs, I think, work a lot better than acetaminophen.
I have no concerns about prescribing NSAIDs based on non-union, malunion, or delayed union. I may have concerns about NSAIDs for other reasons with regards to that individual, but the idea of non-union would not prohibit.
I would
me
agree.
From yeah, I mean they're going to be on it for short term. There's no high quality evidence that says it causes harm. So.
And just for the sake of just poking a couple holes in this paper too, they looked at, they had no idea if the patients, these are based on prescriptions of NSAIDs.
Yeah.
They don't know if the patients actually took the NSAIDs. They also don't know if the patients that weren't prescribed NSAIDs, if they went and got them over the counter.
Yeah.
So, I mean, the whole study design also
It
has its
doesn't
own
help
issues.
us solve the issue.
No.
But the other thing is, it says, continued use of these medications over a period greater than 3 weeks. If they're still having pain 3 weeks into it, something else is up. Yeah.
Yeah, or is it the non-union that's causing the pain and then causing them to take NSAIDs or vice versa? We have no idea. Yep. All right. Next.
17?
17.
17, I think, is an important thing to be aware of. This is not the first paper on this by any stretch of the imagination. This is, where is it, Nate? Excuse me. Fasciitis block performed in the emergency department decreases opioid consumption and length of stay in the hip fracture patient. This doctor gets a prize, a gold star for putting in the title. You don't need to read the paper. The whole answer's in the title. Basically, you ought to do this. When you get down into the specifics, this is 98 patients, and when they looked at the opioid use, it was half. The opioids before the patient went to surgery, when they're still in the ER, after the surgery, all of those kinds of things, it was half. They got out of the hospital a day earlier as well. And there's this idea about you got to get on these, you got to treat them early. You can't put them, they can't come in on Friday night. They can't be operated on Monday morning. So it's orthopedists are probably aware of that because these are generally older people. A lot of morbidity comes if you don't get on them, and the ability to use less analgesics, get them out of the hospital, get them up, walking quicker, all begins in the emergency department. And you might think, well, it's only a matter of treating their pain while they're here, and it's not that at all. This carries into the hospital. They're right before their surgery. The whole kit and caboodle begins with you. So this is a pretty straightforward block to use when you have ultrasound, and I think that it should be viewed as standard. One of the things I thought was unusual in this case is they said that 22 people of the 98 did not qualify, which is strikes me as kind of like that's really high when you look at what it takes to not qualify for this block. It's hardly anything.
Well, no, that was the question I was going to ask. A lot of these people are older and they're on Doax or Coumadin. Mm-hmm. So the question is, the Coumadin, you can make an argument, you could still use it, but if they're on, Xarelto or Eliquis,
I don't think that matters. From what
you got to, you're poking around that muscle.
Yeah, but you got an ultrasound. You're right on top of that thing, kind of thing, and you're going to buy all of this good stuff if you do it. Versus, well, I may get a bleed there, kind of thing.
Has anyone used this, the fascia iliaca for hip fractures?
Oh yeah.
You're curious.
Yeah.
It is fantastic.
Yeah.
It is fantastic. It is just one of those things. The few things that we can do for patients is get them out of their pain. Get them out of pain. And this is just an easy way to do it. I personally am so far behind the current trainees in terms of ultrasound skills and I've given up ultrasound for a lot of things, but this is one of those places that I think it's worth developing the skill set because it can just patients appreciate it.
And I have to transfer my patients to
I.
the orthopedic center, and so you give them some long-acting version of this, and it's like what is it called? Horseshoes and hand grenades. You just dump a bunch of 30, 40 cc's in there. Whoosh, and they're good for 6 hours until you transfer them out, and that bumpy ambulance ride to the center of
that,
excellence.
That also doesn't mean, though, when they hit the door, I'll still give them some morphine or something early on. And then you can get the block in there and go from there.
Yeah, and there have been studies looking at like morphine versus this, and this tends to do well.
And I would be apprehensive about people on DOACs and warfarin and stuff like that. You know, it doesn't mean I won't do it. It just means I'd be less likely to do it.
The only group I have the most trouble with doing is you get the demented patient who comes in with the fractured hip, and it's like, did it work? It's like, oh, Sonny, how are you? Did your leg still hurt?
It hurt? Yeah. All right, so 18 is an RCT comparing efficacy of 5 oral analgesics for treatment of acute musculoskeletal, is that right? Skeletal extremity pain in the ED. And this fits with a lot of the other literature that's been published on, low back pain. This is looking at extremity pain. They looked at all these, 5 different treatments in 600 patients, and they found that the change in pain from baseline to 60 minutes did not differ depending on which treatment you used. So whether it was acetaminophen, whether it was ibuprofen, whether it was a combo, whether there was opioids, it didn't have a difference on efficacy, but certainly the more opioids that were involved, the more nausea and vomiting and side effects that you had. So pick what you would like.
Which rolls right into number 19, which is where they looked at if you had somebody with musculoskeletal pain who you gave ibuprofen to and they were refractory to it for pain control, whether you gave them acetaminophen or acetaminophen plus oxycodone, which worked better. And it seemed that the oxycodone seemed to work better. There was a mean decrease in the pain score by 4.0 in the combination group versus the acetaminophen alone, which kind of makes sense because if you look at it, ibuprofen and acetaminophen are about equal in their analgesic, capabilities. And so if they failed one, they're probably going to need something a little bit stronger than that for the second go-round. So it would make more sense that if they failed the ibuprofen, that you probably are going to have to give them a little bit more than just acetaminophen the second go-round.
Abstract number 20, continuing on the theme of pain control, which is, this is a randomized controlled trial of ibuprofen versus ketorolac versus diclofenac for acute non-radicular low back pain. So this was a study that looked at 3 different regimens of oral NSAIDs: ibuprofen, ketorolac, which we're used to given as an IM injection, but in this study they gave it as a PO regimen, and then diclofenac, and they basically gave all of these as 5-day regimens, 15 tabs, Q8-hour PRN for acute atraumatic non-radiating back pain, and they looked to see, their primary outcome was based off a scale called the Rowland-Morris Disability Questionnaire, which looks at functionality and some pain metrics related to back pain. And in terms of statistical significance, they were about equivalent, but there were some signals that maybe the ketorolac group did a little bit better on that scale. But, and then the thing that sort of like really stood out to me was in terms of adverse events, they asked people about their stomach irritation after these regimens. And in the ibuprofen group, 26% reported stomach irritation. In the ketorolac group, only 5%, and then in the diclofenac, 9%. I think the study is small. I wouldn't make any definitive sort of practice-changing habits out of this, but it's an interesting little signal that somebody should study further. But I'm still sticking for ibuprofen for now. It's where the best evidence is, but there's some interesting little signals in here.
Dr. Mallon would say about ketorolac in terms of its GI effects, the Black and Decker stomach wrecker.
Yeah, it doesn't make a whole lot of sense from what we see from ketorolac.
So for the ibuprofen dose, would you use 600?
This is what they used.
Would you use 600?
I usually go a little bit lower,
so
400, but 600 is an it's not an unreasonable dose.
So no, it's not unreasonable, but the Sergei Motov has done those dosing studies for both ibuprofen and ketorolac and showed that, there is a ceiling effect, right, to NSAIDs. The higher you go, you don't get more analgesia, you get more side effects. So the reason they may have had more side effects in this study is that they used 600 milligrams, because the equivalence studies of using 400, 600, and 800 of ibuprofen found no difference in efficacy at 400, 600, or 800. But the higher you go on the dose, the more likely you are to have the side effects. Same thing with ketorolac. He did the study on 10, 15, and 30 IM and showed that no difference with regards to dose, right? Because of a ceiling effect that we have with NSAIDs. And the other thing is, with regards to treating low back pain, there are so many studies out there that show acetaminophen doesn't work, ibuprofen doesn't work, adding a benzo or a muscle relaxant doesn't work, non-pharmacological therapy for atraumatic low back pain doesn't work, whether it be acupuncture, chiropractic, physiotherapy. It's just about setting expectations when you've got a sore back, a patient with a sore back. It's setting the expectations. The one way they could have gamed this, though, is to, you could have had a placebo control. That would have been nice, right? Taking 3 times a day and comparing it to see if any of these treatments had a benefit. And the other thing they could have done is they could have done the ketorolac IM, because we know that the more invasive the treatment, the higher the subjective outcome with regards to pain control. Right? And the classic example of this is in the 1950s, when they used to didn't have a treatment for angina outside of not very good treatments for angina. They would take these patients to the OR and tie off the internal mammary artery to shunt more blood to the heart, because obviously it's a supply and demand problem, and you get more blood to the heart, and that'll make a difference. And so they did a sham trial back in the 1950s where they identified the artery, tied off the artery in some patients, and didn't in the other patients, and closed them up. And what do you think the outcome was, whether they tied the artery off or not? They all got, almost everybody had a significant improvement. Some people, it cured their angina, and they actually didn't even have the artery tied off. So if you gave this as an injection, you're more likely to get a positive response.
Yeah, that was because their sternal pain just overwhelmed any anginal pain.
Well, no, but they've done this with all the orthopedic sham surgeries for arthroscopic surgery. Oh, let's just flush out those evil humors, right? And so they've taken, 50% of the people got their joint violated and flushed out, and 50% went to the OR, had a little surgical incision on the skin, and all sent back to the recovery room, and nobody knew which group they were in, and there was no difference in outcome for pain post-op. So the more invasive it is, the more powerful the placebo can be.
Except you couldn't give the IMs for these 5 patients.
Because they went home.
They went home.
Oh, well, I mean, they could.
Right, they
And
could.
some people do take needles regularly. Anyways.
Yeah, that would be a high satisfaction rate. Here's a bunch of syringes you could take home.
Yeah, it depends on your practice environment. Olecranon bursitis.
Olecranon bursitis. This is a study of 264 people who had 266 cases of Olecranon bursitis. It means like a couple of people had it on both sides. You just can't win, But in any case, the idea had been, we're going to put a needle in these, we're going to drain these kind of things. We think it's purulent, it's red, it's tender. So we think that we all know that if it's an abscessy kind of thing, or that it's analogous to that, well, you got to drain out the evil humors, and it'll get better quicker. Well, these guys said not so fast. They sent some of these people home who they didn't feel infected. Ultimately, they get down to 147 people who they thought were infected only by a record review where they got antibiotics. So the gold standard here was looking at the record, and they were given antibiotics, so that the implication was, well, they must have been infected. Well, we know that that's not going to be the case. And anyway, 88% of them did just fine on antibiotics only, without having any kind of invasive thing in the elbow. 88%. So what do you think? This is kind of like, I think, like peritonsillar abscess. You had to drain that thing. Everybody knew that. You had to put a scalpel right by the internal carotid artery and go like that. And but now there's studies that say this gives them steroids and antibiotics, and they'll do fine.
Here's the problem with this thing. Everybody I've ever seen with the cellulitis over their elbow gets sympathetic swelling of the Olecranon bursa. So how do you differentiate just a cellulitis with a swollen bursa versus.
Well, I'm suggesting that their gold standard really stunk.
No.
But
It didn't seem to matter, though.
it didn't seem to matter. Exactly right. So how many you routinely needle them? Because I think I do it because I thought it was fun. You know, it was easy. You couldn't screw it up.
It's a big target, too, right? It's like this big...
And a big bulge went down. You know, everybody was happy. But now they don't. You know, you don't need to do that.
I don't think I've tapped some elbow in like 20 years.
Well, you're a Canadian. You know, you have no scalpels up there.
Yeah, but there's a difference between someone who's got a fever and a swollen joint.
That's different.
Versus a.
Then we're talking sepsis
Yeah.
here.
Well,
and
some
stuff
of these
like that.
people some of them were admitted.
Yeah.
We're talking about the ones that went home with antibiotics that were not,
Without aspiration. Yeah, 88%.
and they did just fine for the majority. So you can feel okay. Maybe a few of them will get into some issues or not doing better when they come back or get worse. But the vast majority are going to do okay if you feel reluctant to needle this thing and deprive yourself of the joy of that procedure.
Yeah, I mean, there's some problems with obviously with potential harm, and it just swells up again within 2 days. They're right back at square one with regards to that. But I mean, if they've got they can't even move their elbow, right? And then you're talking about septic joint. I mean, we just don't do this in isolation. I did a podcast on this 2 weeks ago and interviewed the lead author. So if you want to have a deeper dive, a 20, 30-minute conversation on this whole idea, I interviewed the lead author 2 weeks ago, and that's up on the SGEM.
Where is he from?
It's a she, actually, I think.
U.S.
Yeah, oh, yeah, they're from the U.S.,
Okay. All right, moving on.
Is there something other than America?
Moving on.
I'll just clarify that.
22? Anybody? 22?
22 would be Ken.
That would be me. I'm just confirming here the name of the lead author because it's eluding me. Where is she? Ah, yes, there she is, Rona Campbell. She was the senior author on it. All right, so 22, effective diagnostic strategy using an elevated an age-adjusted D-dimer threshold for VTE events in the emergency department with patients of suspected pulmonary embolism, a randomized control trial. So what they were trying to do here is to prospectively validate a strategy of using the years criteria with pulmonary embolism rule-out criteria, that's the PERC rule, right? And an age-adjusted D-dimer threshold. You guys are familiar with that? The times 10 their age, over 50. And so they did a cluster randomized control trial, which was a non-inferiority study design that they used. It was done in France and Spain. They had 1,400 patients who had low risk clinically, because that's how you get into it, right? You had to be low risk, but you couldn't exclude the patients by using the PERC rule. And so they got D-dimers. And then they looked at, the primary outcome of who got a VTE in 3 months. And when they did this, they found that of those 1,400 patients, they did a per protocol analysis, which is what you're supposed to do with a non-inferiority study instead of an intention to treat analysis. And patients with suspected PE, the use of the years rule combined with an age-adjusted D-dimer did not result in an inferior rate of thrombotic events. So it looked like it was okay. Anybody here age adjusting? I've been age adjusting for like 4 or 5 years, and I'm starting to use the years criteria more now with this. So.